So we're here today to discuss our experience in implementing an AI tool in a public hospital, specifically in the NHS. Um, Before starting, we thought we'll give you a bit of background on who we are and how we came together and why we chose this specific project and what our goals are. About a couple of years ago, when I started getting involved in AI and imaging, I started realizing, because a lot of AI companies start approaching us, as to maybe do some study or a trial in the hospital. So I started trying to think, what is the reason that AI teams or individuals why are they actually initiating that AI project? Is it because they've got some problem and they're there trying to think, is there an AI tool that can help this? Or is it a bit more industry-led, where you get a call or an email and it's a lovely product and you think, wow, this could be great, right, for our department? So I started chatting with teams around the UK, and I realized it was more the latter, okay, a bit more industry-led. So personally, I felt, okay, I think this is a time for us to formalize a team now and really try and start projects more from a problem-led approach. So this is why we came together in Southwest London. We wanted to make sure that the team is made up of various stakeholders with a wide range of expertise. And we wanted to learn from each other as much as possible, and we work collaboratively. And start evaluating all these AI tools together as a team. And effectively, in the end, what we really like to do is minimize those obstacles as much as possible to make our AI journey as smooth and effective as much as possible. So the next step was to build a team. The little bit of a challenge was, first of all, the thing that really helped was getting the okay from the executive team. But we were told, if we're going to do this, it's going to be the southwest of London, and that covers 5 hospitals. So we felt it was important to get strong representation from each of these hospitals. So that took a bit of time. However, this is what our team looks like. So we've got the AI lead, and then there's the local champion, which is very important, someone at the site which is working on that specific project. And then we were very lucky to have Susie being our chief research investigator, so that was great. We've got an operations lead, integration lead. That member of the executive team, they don't really do anything really, but they just okay things for us, which makes things better. We've got information governance lead, IT lead, and then education and training lead. So this is a bit of a summary of how we're trying to approach things. So our main aim is to try and standardize our pathways so that whether we're working on a project or a separate team's working on a project, we try and follow a similar sort of roadmap. Again, as I said, we're really trying to look at problem-led projects. What we're trying to do, and we think really helps, is bring in stakeholders from day one. And then if we think it's worth doing, we'll try and create a business plan and maybe deploy and scale. But then also in parallel, we realize the importance of having an educational agenda for all the stakeholders. We're always trying to collaborate and network, not only with people within our trust, but across between trust with research institutions to try and work together, again, learn from each other. And also, we're trying to work collaboratively to improve the data access and the IT infrastructure, especially between hospitals. So we're going to be talking specifically about the project we're doing, but the real reason we're doing it is because it's the first time we're working on a project where the team members are from 5 different hospitals, but it's actually implemented in 2 hospital sites. So we're trying to work together to try and build that infrastructure and create these roadmaps. So far we created a clinical roadmap, a commercial roadmap, governance, research, IT. And the aim is so that in our next project, hopefully these guidances will help us and we're not repeating and doing the same mistakes, or just try and standardize it. And also other teams who are not doing another separate project, hopefully they'll find these helpful. And then the other thing is organizational culture. I mean, that's so important, right? That we start doing these projects so that people become more data savvy.
Geraldine. So can I have my microphone on? Great. So to put our team to the test, we needed a project to actually work on. And we wanted to start small first and make sure we have early successes. So we chose to do this in one of the hospital networks of the 5 that Jerry was speaking about. And the one we chose to do this at was Epsom and St Helier's Hospital. I know you probably have never heard of this in Europe. It's not the biggest hospital team in the world, but it is just situated outside London. You can see the big brown circle is central London. If you've ever been to London, that's where Buckingham Palace, the Tower of London, is based. And Epsom and St Helier's are 2 hospitals just on the outskirts. Takes about an hour by public transport to get there if you're coming from central London. So the main objectives of our project were, number 1, what should we use AI for? This was a big brainstorm that happened in the department, and one of the key priorities of the hospital was to try to implement faster, smoother triaging of lung cancer to CT and onward to multidisciplinary team meeting. So that was the problem we identified and wanted to tackle. The second one, which I was very interested in, was how can we change the attitudes and opinions of staff within the NHS on how they see AI? Because you talk to a lot of people, and a lot of people have different ideas of what it is, how it should be used, whether it's good or evil, and I wanted to evaluate that and see whether that changed during the course of this project. And as Geraldine already said, we wanted to develop guidelines, standardized pathways, so that if we had to repeat the project with a different use case, we could do this really smoothly and fast-track it rather than start from scratch again. And everyone knows it's really difficult to get funding for AI, so a health economic evaluation in the future would be something we really want to work towards so that we can fund and promote more AI tools for our centres. So I don't know if you have this in other countries, but in the UK, we have something called a National Optimal Lung Cancer Pathway. It's such a mouthful, NOLCP for short. Essentially, what that means is that there is this aim to achieve a timeline of 0 to 14 days from when a patient may have symptoms of cancer to when they get discussed at the tumour boards for onward treatment. And ideally, their imaging, that means their chest X-ray and their CT, should be done by day 5. And by day 14, they should have that discussed at the tumour board rounds. In Epsom and St Helier Trust, we were getting, from a previous audit, getting all the imaging done by day 5 in only 66% of cases. So there was still a lot of room to improve on that. Just an idea about how big this hospital trust is, we have a total of almost 200 staff there, and of those, 29 would report chest X-rays and look at them. As I mentioned, there were prior audits to see how well we were coping with this NOLCP pathway. And in 3 months during 2021, we had almost 6,000 chest X-rays referred from family practice by patients who had symptoms of possible lung cancer. And eventually, 86 of those had a CT and 11 were eventually confirmed to have a malignancy. But as I say, potentially they could have been picked up sooner. Maybe there were some that we missed. We don't know. But we were only achieving the optimal outcome in 66% of cases. So we wanted to see if AI could help us, and that's why we chose this as a clinical problem. So here, Jerry, do you want to discuss?
So this is an example of one of the roadmaps we created. So we call this the first step clinical roadmap. And looks simple, but it really helped us. And I really hope we'll use it again in our next project. So essentially, let's say we'd want to start an AI project for the first time in a hospital or whatever. First, we started looking at all the problems that we have in the department, and we listed them. And then we looked at, are there any AI tools that can help with any of these problems? And then after identifying, okay, this is the problem that we're going to tackle, we agreed on the AI tool that we're going to use for this. And then we went and did a market research of all those AI tools available. So in this case, it was chest X-ray AI tool. I think at the time there were about 16 with a CE mark, something like that. And so it can be quite daunting, because how do you choose? So what we did was, first from the 16, we sort of narrowed it down very quickly to 6 or 7. And then what we did do with the whole team, we essentially took a vote and decided on one product. But the way we went about that is, what really helped is that within that team, there were people with different expertise. So I was the radiologist, for example. I was the user. I'm looking at things from one perspective. But then there was the integration lead guy, and he was looking at things from another angle. And there was the IT guy as well, and there was the governance lead. So together we made that decision, and it was very helpful, because then I feel we had less obstacles down the road, because we knew this might actually work. Because there are a lot of great products out there, but I think it's very important to choose that specific product that will help your specific department and your specific problem.
Great. So the product that was eventually chosen was Annalise AI. It was chosen for many reasons, as Geraldine said, but it was a shared combined choice from different stakeholders. So shared responsibility. As you can see here, this is a demonstration of the product. It's very intuitive and simple to use. It gets an automatic AI algorithm run on every X-ray that comes in through the system. You can see there's a little menu with all the different options of different pathologies that are picked up. And if you click on any pathology, it'll show you a segmentation on the actual image as to where that pathology is, so you can see what the AI is looking at. Specific to this particular implementation project, we had a little feedback key that you can see on the right. So whenever you saw any particular pathology, if you agreed with the AI, you could click the star to say, yes, I agree. You could click the X to say, no, I disagree. Or you can put a little finding in, add your notes, or say, great pickup, or massive fail. You don't have to click on this feedback if you're just using the tool in everyday practice. But we asked our staff to do that because we wanted to evaluate how good the tool was in this implementation study, to know whether it was being used correctly, effectively, and whether the outcomes were great. So don't feel you have to go through all this clicking. It's not necessary, but this is what we've implemented in this trial. So this is just a little bit about the patient pathway. How are we using AI? What was the historic patient pathway, and how is it now being changed? So before October of last year, what would happen at Epsom St Helier is you go to your family GP, your family doctor with cough, hemoptysis. The GP thinks, maybe you've got lung cancer, let's go for a chest x-ray. So you go to Epsom St Helier Hospital, have your chest x-ray taken, and in the past they would say, hello, goodbye, go home, we'll call you if there's anything wrong. And a radiologist or a reporting radiographer would look at that, report it within 48 hours, and if there was something suspicious, then a secretary or administrative staff would call you up at home and say, there's something wrong, please come in to have your CT chest. We can do it within the next 3 days. You would hopefully get that within the next 3 days on day 5, and then by day 7, that should be read and reported by a radiologist. However, since October, what was happening was a same-day CT service was being implemented, where the radiographer now would look at the chest x-ray that was taken, and if there was a big mass or something that looked abnormal, they would then call the radiologist, who would then say, let's get a CT today. And then you would have your CT sooner, reported sooner. But the radiographer's busy. They may not always pick up everything. They may not always look at all the chest x-rays in such detail. So since December of last year, we have now implemented the Annalise AI product. It picks up 120 plus types of abnormalities, but we've selected the top 13 that we feel are relevant for lung cancer. So now all the chest x-rays get run through the AI. If it picks up any of those 13 pathologies, it flags it up to the radiographer. They would then call the duty reporting radiologist, and within 30 minutes, that will either be reported to say, yes, please go for a same-day CT, or no, don't worry, send the patient home, there's nothing to worry about. So now the patient would stay in the department, wait to hear within 30 minutes if their chest x-ray had a real abnormality or not, and then they would have that CT the same day, and by day 2, that CT would be reported instead of waiting by day 7. So we're hoping to try to shorten that pathway by a few more days so that they can be seen at the tumour board rounds a lot faster. So As I've said, it hasn't been running for very long. It's only been a couple of months, so we don't have any actual outcome data of how much faster we're seeing patients yet. We're hoping to run this trial for 6 months, and then at the end of the 6 months, by end of June, we should be having some outcome data on whether it's worked and helped patient outcomes. We want to compare that timeline of that 6 months with the prior 2 months when we were having radiographer triage without the AI. We also want to compare that with the 3 months prior, where we didn't have same-day CT, we didn't have AI, and then also, just to show us how far we've come, compare the same 6 months now to 6 months this time last year and say, actually, look how far we've come from even a year ago. And that's partly because, referral for chest x-ray can be seasonal dependent. Winter times are always a time where there's way more referrals. So we didn't want to just say, oh, let's compare summer months to winter months. So that's why we've got different time periods that we're comparing with. And the outcomes will be time to CT, how accurate the AI was at picking up appropriate lesions for a referral, and also how quick we were at triaging and whether patients liked it, and the evaluation of the staff attitudes to that. Speaking of which, we're coming on to staff attitudes. We devised a survey as well that we wanted to implement across our department in Epsom St Heliers to find out attitudes, the hearts, the minds of our staff. And so we've circulated the same survey in the month prior to starting the AI, asking everyone in the department, what do you think? It's quite a long survey of almost 20 plus questions. We've now also circulated the same survey a month ago to say, how do you feel about AI now that you've seen it in action? And we will repeat the survey again at the end to see whether things have changed. And I just want to share with you the outcome of some of the questions there that I thought were the most interesting. So the first thing that we asked, bear in mind, there's only a small number and we're still doing this study, but we asked people before we implemented AI, which one of the following factors, positive factors, do you think introducing an AI tool would bring to the department? And you can see in gray, the bar chart is what happened before AI was implemented, and the blue is after. So before AI was implemented, everyone thought it would save us time. They thought about the radiology department. They weren't thinking very much about how it would affect the patient. But you can see actually after implementing AI, people do feel now that it will help patients a lot more, and they're not just thinking about efficiency and workflow. So they can see that there is a patient impact, even though I can't share with you that data just yet because it's ongoing. We asked them also, which one of the drawbacks do you think introducing AI would bring to the department? And prior to implementing, they thought it would increase costs in the department. You can see down at the bottom that biggest gray line there. And I think they thought it would be costs of training, costs to buy the tool, costs for IT implementation. But actually, at the bottom, after introducing the AI, they thought actually it would increase workload for the radiology staff. And I think that's a little unfair because remember, this is very early days, and when you implement anything, there are going to be bumps along the road. And we are asking them to click on the feedback for each case, which does increase the number of clicks. But as I've said, you don't have to do that when you use this tool. We're just using it in this trial. So I feel that's why people are saying increased workload, not because it actually does, but because for them it has in this early stage as we're evaluating the tool. And then the last question that I thought was quite interesting to pick out from this survey was asking them if they would be comfortable having AI used on their own chest x-ray. And in the beginning, you can see the gray bar is highest in number 3. So they were kind of like, I don't know, I'm not fussed. Would I be comfortable? It's kind of like a 3 out of a 5. But actually now they've seen AI in use. The largest tool, the largest bar is actually at number 4. So they're being swayed to saying, actually, I would be happy having AI used on my chest x-ray if I was referred for a possible cancer diagnosis. So it's already changing attitudes, even at this early stage.
So these are some of the challenges we've met so far. These are just a few of them, right? And many, many more to come. But these are quite important ones here because one big issue is this is a really slow process. And one of the reasons for that is a lot of us don't have time in our job plan. I think the managers are not recognizing that this AI could be a thing. So a lot of people are doing this out of their own free time. And it's not easy to convince people in a team to work in their free time, right? So that has been a real challenge. So I think we really want to start and try and speak to managers and let them allow them to realize the importance of giving us dedicated time for this so we can do an even better job at it. The other aspect is the commercial products. Sometimes when we look at all these AI tools, you wouldn't know where to even start. Which one are you going to pick? Especially there's a lack of prospective real-world evidence as well, because that's the sort of go-to usually for us clinicians, isn't it? So that can be a bit challenging. The other thing is IT. For us, bringing in IT from day one was really helpful because we knew whether it's going to work or not. Because I don't know how it is elsewhere, but in the NHS, IT teams are very overworked, and the last thing they want to hear about is some person wanting to do some AI project. So I think speaking with the IT team from day one and getting the go-ahead from them was very helpful. But that is a challenge, the IT. And in our specific circumstance, we're about to change our packs. So that makes it even slightly more challenging. The other thing is the lack of standardized approach. Of course, as a team, this is the first time we're doing it together, so that makes it a bit harder. But hopefully that will set the way for our future projects.
Yeah, so just to summarize, we have a few future steps we would like to do. We're only about a couple of months into this implementation, so we're going to continue this for 6 months, get some more outcomes. We're having regular updates with the Annalise team. We're constantly collecting data fortnightly, and I hope that this time next year at ECR we can actually tell you how it went. We're trying to expand our use case for the AI tool. I mentioned we're only using it for lung cancer triage, but actually this tool can do so much more. So we're going to expand it, turn on a few more of the different types of pathologies, see if we can use it for acute lung pathologies as well, and we're building a business case for funding the AI long term as well, and we're working with our partners from all the different stakeholders to try to make that a reality. So thank you very much to everyone here, and thanks to our great team at Epsom and St Helier Hospital.